Hello, everybody. This is Dr. Gonzalez. I hope that you are doing well. One of my special interests is scope of practice, advanced practice, scope of practice, specifically nurse practitioners, because as you know, or you probably do know, I'm a nurse practitioner. I find scope of practice laws very interesting, and therefore I have done this lecture, which applies to all California students, regardless of their specialty. So if you're in pediatrics, this applies to you. If you're in the adult geri world, this applies to you. If you're in the neonatal world, this applies to you. And if you're in the family MP program, this applies to you. So there's really no differentiation as to does this apply to you or not. If you're a California resident and you're getting licensed in California upon graduation, then this lecture applies to you and you're required to really understand and know what your scope of practice laws are. And those laws go well beyond the Nurse Practice Act in your state. And so what you're going to see today is a variety of laws that have an impact on your scope of practice. We will begin first talking about the nurse practitioner uh, uh, laws as they apply in the Nurse Practice Act for the California Board of Registered Nursing. And then we'll look at laws that are outside of the Nurse Practice Act that impact your scope of practice. And so if you feel comfortable with what you know about what you can and cannot do in California, this lecture may be a bit of a shock to you and may open your eyes a bit, and I hope that's what it does. It's very important that we are all cautious in what we do and we know our state laws, because you can inadvertently and accidentally break a law because you don't know it. And so it's very important to understand your laws for other reasons too, because the physicians you work for, your employers that you work for may not know what your scope of practice is. So it's important that you know what your scope of practice is so that you can say, no, I can't do that. If you know the law, then you can say definitively, no, you can't do that. So, and I am quick in my own personal practice to say, nope, I can't do that because X and X law doesn't permit it. And I practice in Texas. So nothing stops a person dead in their tracks faster than when you say, no, the law does not permit me to do this, and this is what the law says. So for your protection, for the protection of your patients, it is very important that you have a general working knowledge of the California laws. Your Board of Nursing requires you to understand and know these laws and abide by the laws, and doing otherwise may very well end up with you receiving disciplinary action from your state board of nursing. With that, let's go ahead and get started. So the California Board of Registered Nursing, this is a brief overview of the Board of Registered Nursing. The Board of Registered Nursing is a state governmental agency established by law to protect the public by regulating the practice of registered nurses. The BRN is responsible for implementation and enforcement of the Nurse Practice Act, which is the laws related to nursing education, licensure, practice, and discipline. The Nursing Practice Act created a 9-member board which serves as the Board of Registered Nursing decision-making body. The BRN is made up of 4 members of the public and 5 registered nurses. The registered nurses include 2 direct patient care nurses, an advanced practice nurse, a nurse administrator, and a nurse educator. 7 members are appointed by the governor, and 2 public members are appointed by legislature. Each member serves a 4-year term and can be reappointed but cannot serve more than 2 consecutive terms. Regardless of the setting or the title, the RN's practice is governed by the Board of Registered Nursing. This means that you are responsible for following all Board of Nursing laws and regulations that apply to RNs and APRNs. Just because you graduate and now you are and you're a nurse practitioner does not mean that those rules that apply to RNs no longer apply to you. You are obligated to follow more rules now, not less rules. The Nurse Practice Act is the body of California law that mandates the board to set out the scope of practice and responsibilities for all registered nurses. The links, I took this information directly from the Board of Nursing website, Board of Registered Nursing website, and the links are provided there on your screen. California Nurse Practice Act. This can be found in two separate sections of California law. It's found in the California Business and Professional Code and in the California Code of Regulations. So the plan for this lecture is to review the content specific to NP practice in California as it's outlined in the Nurse Practice Act, and then review a number of other laws which shape your scope of practice in California. How does the California Board of Registered Nursing define NP scope of practice? So let's look at three case scenarios. An FNP is working in an ICU setting. Is this appropriate? An AGA CMP is working for a family practice clinic seeing patients 18 and over. Is this appropriate? A pediatric nurse practitioner certified in primary care wants to work providing primary care to adult patients. Is this appropriate? So the California Board of Nursing does discuss these type of scenarios, and on the next slide we'll look at that. So the Nurse Practice Act in two different areas gives us information to answer the question, how does the California Board of Nursing define NP scope of practice, and to really analyze those scenarios with the FNP and the pediatric NP and the acute care NP. So in the Business and Professional Codes Division 2, Chapter 6, Article 8, titled Nurse Practitioners, they write the following. Drugs and devices ordered must be consistent with the practitioner's educational preparation. That means that one can only prescribe therapies or order drugs for patients that fall within their scope of practice. A family nurse practitioner is trained in primary care. Therefore, their education has not prepared them to work caring for patients that have that fall within the acute care NP scope of practice. They are not trained on the diagnoses or the medical management or the complications of the diagnoses of individuals who are critically ill. And while a number of people feel that FNPs working in the ICU may be appropriate, unfortunately, they could not be any further. That could not be any further from the truth. The reality is that there's not one there. FNPs are not trained to provide care to those critically ill patients, and that is why we have a whole separate program for the acute care NP, because the focus for the acute care NP is acutely and critically ill patients. So anyway, so the Board of Nursing says basically with this statement that you have to work within your educational preparation. One thing to remember about your scope of practice is that the foundation of your scope of practice is your education, so the type of program you graduated from, your certification, which validates your education at the national level. You can only get certified in the area in which you graduated from. So an FNP can only sit for an FNP certification exam. An acute care NP can only sit for an acute care NP exam. A neonatal NP can only sit for the neonatal NP exam. And the third pillar of your scope of practice is licensure, and that is the legal authority from your state to practice within their state. So the second section of the Nurse Practitioner, the Nurse Practice Act in California that helps us to answer these questions is California Code of Regulations, Title 16, Division 14, Article 8, titled Standards for Nurse Practitioners. In Section 1480, they define clinical competence. So in this section, they say clinically competent means the individual possesses and exercises the degree of learning, skill, care, and experience ordinarily possessed and exercised by a certified nurse practitioner providing health care in the same nurse practitioner category. The clinical experience must be such that the nurse received an intensive experience in performing the diagnostic and treatment procedures essential to the provision of primary care. So they further go on to define acute care and primary care. And acute care means restorative care provided by the nurse practitioner to patients with rapidly changing, unstable, chronic, complex, and critical conditions in a variety of clinical practice settings. So primary care means comprehensive and continuous care provided to patients, families, and the community. Primary care focuses on basic preventative care, health promotion, disease prevention, health maintenance, patient education, and the diagnosis and treatment of acute and chronic illnesses in a variety of practice settings. So in order to ensure that you are practicing within your scope, you need to know that California defines acute care in one way and primary care in the certain way. And these definitions apply to the adult geriatric population, applies to the pediatric population, and it applies to the FMPs. So if you're a neonatal student listening to this lecture, the nice thing about neonatals training is that you guys are trained across practice settings, and you're trained so you can move in and out of the hospital, and you are trained to care from premature babies all the way up to 2 years of age. So you can, as a neonatal NP, you can work outpatient and you can work inpatient. As an FNP, you're stuck in providing care for primary care, providing care to those patients who need primary care that meet this definition. Now, if you notice both of these, acute care definition and primary care definition says in a variety of clinical practice settings, because the general consensus nationally is that nurse practitioner scope of practice is not defined by the practice location, but rather the patient's needs. And that's what they're saying here, is that it is the patient's needs that define the scope of practice. So an FMP may not be appropriate to, is not appropriate to work in a critical care unit, dealing with vasopressors, managing the vent, those type of things. But if the patient needs traditional sub-Q insulin to manage their diabetes, and that's all the nurse practitioner, the FMP is doing, or a primary care trained NP is doing, then that's probably well within the scope of practice of the FMP, because that is considered an activity of primary care, even though the patient is set in critical care. So anyway, keep that in mind. If you're primary care certified, then you should only be providing care to individuals who meet the definition of primary care, and the same holds true for acute care. You should only treat those patients who fall within this definition of acute care. And these are national definitions that come from national nursing policy that your board of nursing, your board of registered nursing has adopted. So what does this all mean? I've already explained what it really means, but just briefly, this means that you have to work within your educational preparation, your certification, and licensure. These are what define your scope of practice and what the Board of Registered Nursing will examine to determine your scope. None of these scenarios are appropriate despite what you may have heard. And one thing I want to caution you about is just because you see somebody that is doing this does not mean that it's okay, and it does not mean that it's appropriate. You come out of this program knowing what's right and what's wrong, and then you are the champion for leading that initiative and holding yourself accountable for appropriate practice. So again, an FMP is not trained or educated to work in the ICU setting, and it's not within their scope of practice unless the care that they are providing is related to or falls within that definition of primary care. Like the example I gave you, if the patient only is requiring sub-Q insulin to manage their diabetes in the ICU, then that would be an okay activity for an FMP or any primary care trained NP in their patient population to take care of. An AG-ACNP is not trained to provide primary care, and a primary care PMP is not trained to provide care to the adults. So none of these scenarios are really appropriate. So let's go ahead and move on and talk about some specifics in your Nurse Practice Act. If you remember, I told you earlier that the Nurse Practice Act is located in a couple different sections of California law. So the first portion that we will look at of the Nurse Practice Act is located in the California Business and Profession Codes. Division 2, Chapter 6, Article 8, titled Nurse Practitioners. This is the section of the Nurse Practice Act that contains specific regulations which govern nurse practitioners in California. And we will discuss these regulations in the next few slides. So let's look at another case scenario. You are graduating from NP school soon, and your family is so proud of you they continually introduce you as a nurse practitioner. Is this legal and permitted in the state of California? So Division 2, Chapter 6, Article 8, Nurse Practitioners, this portion of the Nurse Practice Act is what answers this question for us. The answer is ultimately no, but in this portion of the NPA, you'll see why. And so this portion, as it relates to nurse practitioners, states that the title nurse practitioner is a protected title in California. One may not use this title without being appropriately licensed and meeting the standards for nurse practitioners established by the board. So ultimately, that alone tells you that this situation is not legal and not appropriate. You cannot use the title nurse practitioner until you are officially licensed by the state of California. As of January 1st, 2008, an applicant for initial licensure in California must meet the following qualifications. They have to hold a valid and active RN license in California, have a graduate level of education, which is an MSN or higher, or a master's degree in a clinical field related to nursing, complete a nurse practitioner program that is approved by the board, and based on the Nurse Practice Act, the board says a graduate from a board-approved nurse practitioner education program shall be considered a graduate of a nationally accredited program if the program held national nursing accreditation at the time that the graduate completed the program. The program graduate is eligible to apply for nurse practitioner certification with the board regardless of the program's national accreditation status at the time of submission of the application to the board. So you can find that you can find the language there. Ultimately, UTA is accredited, fully accredited, and there should not be any licensure issues for you in the state of California. So please also note that the Board of Registered Nursing has a licensing option for programs which are for graduates who attend an out-of-state program, and I discussed this in detail in the California licensing video, which is provided to you in the final practicum course, so your last course before graduation. This portion of the law is establishes the authority for the Board of Registered Nursing to establish categories for nurse practitioners and standards for nurse practitioners to hold themselves out as an NP. Okay, so let's look at our next case scenario. You are graduating from a nurse practitioner school soon and are applying for NP positions. During one of your interviews, the potential employer asks you if you have to have a standardized procedure to work. You say, I don't know because you haven't had this lecture yet. So what is the correct answer? Ultimately, the correct answer is yes, but let's see why it's yes by looking at the specific laws. So again, it is Division 2, Chapter 6, Article 8, Nurse Practitioners of the Nurse Practice Act that helps to answer this question for us. Standard procedures are written protocols which must be developed by yourself, the employer, and the physician. They outline what you can and cannot do as an NP in California. This portion of the Nurse Practice Act establishes the requirement of the use of standardized procedures and states the following. Standard procedures may be developed which allow the nurse practitioner to do the following tasks. Order DME, subject to limitations set in the standard procedure. Certify disability only after physical exam has been completed and done in collaboration with the physician and surgeon. So ultimately this means that you have to be working in collaboration with a physician and surgeon in order to certify disability, and you actually have to see the individual in order to certify that disability and do an exam. So finally, approve, sign, modify, or add to a plan of treatment or plan of care for individuals receiving home health services or personal care services after consulting with the treating physician and surgeon. So this is important for you to understand that you can alter the treatment plan for these individuals in home care or personal care services, but you have to consult with the treating physician and surgeon first, whichever is the case. So you cannot just make the alteration. You have to consult with the physician first, then you can make the change, and ultimately you will be responsible for documenting that you consulted with the physician. Anything you do like this, you need to document in your chart to show compliance with the Nurse Practice Act. Um, All right, so one thing to remember about standard procedures is that this is the only way that you can practice in the state of California. California, just like Texas is, they are both supervisory states, and everything that you do in the state of California is a delegated act from the physician. Um, so that's anything that you do as a nurse practitioner, your diagnosis, your evaluation of your patient, your medical management, all of that has to be delegated by a physician. And so your standard procedures should outline all the tasks that you are able to do and in some instances not able to do. But we will talk about a little bit more about standard procedures a little later. Okay, so let's move on to our next scenario. You have just graduated NP school and your RN colleague tells you she ran out of her blood pressure medication. She asks you to write her a prescription. Can you do this? So again, we're still talking about what Division 2, Chapter 6, Article 8, titled Nurse Practitioners says. And again, this is the same portion of the Nurse Practice Act that we've been talking about. But in this section, it says that the ability for nurse practitioners to furnish or order drugs is granted in this section of the Nurse Practice Act. The nurse practitioner may furnish or order drugs when all of the following apply. So everything that we're about to go through on this slide and the next two slides after this have to be in place in order for one to furnish medications. So let me talk about what furnishing means in California. In California, they use the word furnish to mean prescribe. So when you see furnish, you know that they're talking about prescribing medications. The terminology that they use in California is just a little bit different, and they use the word furnish. So you can furnish medications if all of the following applies. And number one, the ordering of drugs and devices must be done in accordance with a standardized procedure or protocol, which is developed by the NP and the doctor and surgeon. Drugs and devices ordered must be consistent with the practitioner's educational preparation. So this must be within your scope of practice. So you cannot work outside of your scope of practice. The NP must function in accordance with established standardized procedure, which is developed and approved by the supervising physician and surgeon. The nurse practitioner and the facility administrator are the designee. In order to prescribe, which does mean furnish, Schedule II substances, the standardized protocol must address the diagnosis of the illness, injury, or condition for which the Schedule II medication is to be furnished. So in order to prescribe a Schedule II medication, your standardized protocol has to have this specific information in it in order for you to prescribe Schedule II medications. If it doesn't have that information in it, then you cannot prescribe this Schedule II medications. Furnishing or ordering drugs or devices must be completed under the physician and surgeon supervision. This does not require the physical presence of a physician, so that means that you can operate without the physician or surgeon being right there with you all the time. But your prescriptive authority or your furnishing authority does depend on the remainder of those items on the screen, and that is the development of a collaboration protocol that is approved, standardized procedure, documents that there's availability by telephone for the nurse practitioner to consult with the physician at the time of the examination if needed. A physician or surgeon may only supervise a maximum of 4 nurse practitioners, so you can't be with a nurse practitioner with a physician or surgeon who are attempting to supervise more than that. Drugs and devices furnished or ordered by a nurse practitioner may include Schedule 2 through 5 controlled substances under the State Controlled Substance Act. However, the NP can only furnish or order those drugs which are agreed upon in the standardized protocol. So if your physician does not agree to allow you to prescribe Schedule 2s, then you cannot prescribe or furnish those medications. But you can, if he's allowed you to do Schedule 3, 4, and 5, then you can do that. But has exempted Schedule 2, then you can't do that. When scheduled drugs are furnished or ordered by the NP, it must be done so in accordance with a patient-specific protocol approved by the treating or supervising physician. A copy of the section of the nurse practitioner standardized procedure relating to controlled substances shall be provided upon request to any licensed pharmacist who dispenses drugs or devices. So what that means is that you need to keep that with you or have access to it so that if you're called by a pharmacist and asked to see your protocol, that you can produce that for them. So you have to have access to that. The Board of Registered Nursing must verify that the nurse practitioner has completed a pharmacology course. A physician and surgeon may determine the extent of supervision necessary in furnishing drugs and devices. So it's at their will to determine how much supervision that you need when it comes to prescribing drugs and devices. And nurse practitioners with a furnishing number are required to complete a continuing education course on Schedule 2 controlled substances and the risk of addiction associated with their use based on standards developed by the Board of Registered Nursing. So Article 8, Nurse Practitioners of the Nurse Practice Act also says furnishing or ordering of drugs and devices by nurse practitioners is defined as the act of making a pharmaceutical agent or agents available to the patient in strict accordance with a standard procedure. All nurse practitioners who furnish or prescribe controlled substances must be registered with a DEA. So you cannot prescribe controlled substances Schedule 2 through 5 without a DEA first. In order to furnish medications in California, one must meet the qualifications of furnishing and be issued a furnishing number by the Board of Registered Nursing. This number must be included on all transmittals of orders for drugs and devices. So you need to include your furnishing number on your prescriptions and any orders that you write. So we continue discussing California Business Code and Professional Code. And let's look at our next case scenario. You see a job posting for a nurse practitioner to work in a drug addiction facility, caring for patients while going through withdrawal. You wonder if this is something within your scope of practice. So Division 2, Chapter 6, Article 8, Nurse Practitioners of the California Business and Professional Code actually answers this question for you. And the reason this is a question at all is because buprenorphine is often used to treat withdrawal symptoms secondary to opioid addiction, which includes heroin. So it's a very strong opioid, and it helps to relieve some of those symptoms. So it's up until recently, its prescription by nurse practitioners has been limited. So the answer is possibly yes. You have to work within your educational preparation, certification, and licensure. So, and what that means is going back to understanding whether this is an acute care role versus a primary care role. Some of these individuals that are going through withdrawal are very, very sick. So they may fall out of a primary care NP scope of practice. So you have to be aware of that. If they fall into that definition of acute care, then if you're primary care, your hands are off, and vice versa. You can't treat for those patients, so be aware of that. So the Practice Act says that nurse practitioners may prescribe buprenorphine if they are compliant with the provisions of the Comprehensive Addiction Recovery Act, which is the federal law. So ultimately, this act says that you must have 24 hours of initial training by an organization that's essentially approved by the U.S. State Secretary of Health and Human Services, and that the class must include the following: opioid maintenance and detoxification. So it has to include information about opioid maintenance and detoxification, appropriate clinical use of all drugs approved by the FDA for the treatment of opioid disorders, initial and periodic patient assessments, including substance abuse monitoring, individualized treatment planning, overdose reversal and relapse prevention, counseling and recovery support services, staffing roles and considerations, diversion control. Other best practices are identified by the U.S. Secretary of Health and Human Services. So the nurse practitioner, it also says that the nurse practitioner must be supervised or worked in collaboration with a licensed physician and surgeon. So the link for additional information is located on the bottom of your screen there. So we're moving into another portion of the Nurse Practice Act, and this is the portion that is located in the California Code of Regulations. And specifically, we will be discussing Title 16, Division 14, Article 7, titled Standardized Procedures. And we'll look at a case scenario here. And we'll actually go back to the interview scenario. So you're graduating from MP school soon and are applying for MP positions. During one of your interviews, the potential employer asks you if you have to have a standardized procedure to work. You say, I do not know because you haven't had this lecture yet. What is a standardized procedure and why do I have to have it? A standardized procedure is a formal written document which a nurse practitioner must have implemented with their supervising physician and the facility where they work in order to practice as a nurse practitioner. The purpose of this document is to protect the consumer by providing evidence that the nurse meets all requirements to practice safely. This portion of the Nurse Practice Act also provides uniformity for standardized procedures. This portion of the Nurse Practice Act tells you what is required in the standard procedure, and you must follow it, otherwise you are practicing illegally. So the functions of a standardized procedure. The Nurse Practice Act requires an organized healthcare system to develop standardized procedures before permitting RNs to perform standardized procedure functions. A registered nurse may only perform standardized procedure functions only under the conditions specified in the healthcare system standardized procedure. The RN must provide the system with satisfactory evidence that the nurse meets its experience, training, and/or education requirement to perform such functions. So what that is saying is you have to provide evidence of your education and training that is consistent with the activities that you are writing into this standardized procedure that will be co-developed with your physician and the facility. So standardized procedure guidelines, standardized procedures shall include a written description of the method used in developing and improving them and any revision thereof. Each standardized procedure shall be in writing, dated, and signed by the organized healthcare system personnel authorized to approve it. Specify which standardized procedure functions registered nurses may perform and under what circumstances. State any specific requirements which are to be followed by registered nurses in performing particular standardized procedure functions. Specify any experience, training, and/or education requirements for performance of standardized procedure functions. Establish a method for initial and continuing education of the competence of those registered nurses authorized to perform standardized procedures. Provide a method of maintaining a written record of those persons authorized to perform standardized procedure functions. Specify the scope of supervision required for performance of standardized procedure functions, for example, immediate supervision by a physician. Set forth any specialized circumstances under which the registered nurse is to immediately communicate with a physician concerning the patient's condition. State the limitations on settings, if any, in which standardized procedure functions may be performed, specific patient record keeping requirements, and provide a method of periodic review of the standardized procedures. So this is the link to the part of the Nurse Practice Act that lists all this stuff. And so don't get confused with the term standardized procedure and functions. So the standardized procedure is just how the California Board of Registered Nurses labels a delegation protocol. In other states, it's named something different. In Texas, it's a delegation agreement. We've got a couple different ones in Texas. It's called a prescriptive authority agreement, and it's called a facility-based agreement. In California, it's just called a standardized procedure. And so in another state, it may just be called a collaborative practice agreement. So you'll hear a variety of terms throughout your career. Collaboration practice agreement is a general overarching term that most people tend to use. So don't get confused by this, by the terminology, thinking that this only has to do with procedures, like physical procedures, like doing an IND or doing an invasive skill that the acute care students learn, like inserting central lines. So it's not specifically related to procedures. They're using the term procedure and functions globally to encompass those tasks that you do as a nurse practitioner in California, which is the diagnosis, evaluation, and management of patients, including furnishing medications and including physical procedures that you do. So standardized procedure examples and additional information. So guidelines are published by the Board of Registered Nursing and can be found at the link below on your screen. They provide 2 samples that you can use and reference when you need it. Notice that this document from the Board of Registered Nursing states the following. If an RN or MP undertakes a procedure without the competence to do so, such an act may constitute gross negligence and may be subject to discipline by the Board of Registered Nursing. Again, here is the Board of Nursing telling you that you are required to have clinical competence and to work within your scope of nursing or your scope of practice based off of your education, certification, and licensure. So they are again pointing that out to you. So you need to be very aware of where and who you're practicing with. It's the type of patients. Any questions about the Board of Registered Nursing requirements for standardized procedure should be directed to the following email. I know that these are kind of vague and you may not understand them, but the Board of Registered Nursing is the best one to get your questions answered regarding this, because these are their rules and their regulations. Okay, so we're going to move on to the next portion of the Nurse Practice Act that is still located in the California Code of Regulations, Title 16, Division 14, only now we're in Article 8, which talks about standards for nurse practitioners. And so Section 1481 is part of Article 8, and in this section it says that the Board of Registered Nurses recognizes the following categories for nurse practitioners. So family and individual across the lifespan, adult gerontology, primary acute care, neonatal, pediatrics, primary acute care, women's health and gender related, psychiatric mental health across the lifespan. And these titles are consistent with the APRN consensus model that was published back in 2008. An RN who has been certified in California, and in California, being licensed means being certified. And you don't want to get that confused with having your national certification through a national certifying board with a license in California. So they use the word interchangeably in California, certified to mean license, and that's not necessarily the case. Your certifying board, when you hold a national certification from your certifying board, you are certified and then you are licensed at your state. So this can get confusing in California, so be aware of that. So a registered nurse who has been certified, aka licensed in California as a nurse practitioner, may use the title Advanced Practice Registered Nurse and/or Certified Nurse Practitioner. You may place the letters APRN-CMP after your name or in combination with other letters or words that identify your category. In other words, that if you want to use family MP, you could, or AG ACMP you could, or AG Primary Care MP you could, or Pediatric Nurse Practitioner Primary Care you could do that as well. So this portion of the Nurse Practice Act provides you that ability to do that. A large portion of this part of the Nurse Practice Act deals with state licensing requirements for nurse practitioners in California. The specifics are covered in the licensing lecture provided to you in your final practicum course, and we will not go through that right now. So section 1480 discusses clinical competence, which we've already discussed at the beginning of this lecture, and we're not going to discuss that again. Section 1485, this portion of the Nurse Practice Act states that the nurse practitioner shall function within the scope of practice as specified in the Nurse Practice Act and as it applies to all registered nurses. So here in the NPA, they are tying you into those definitions of acute care and primary care and being clinically competent and working within your education and certification, national certification. So you have to be aware of that and be very cognizant of making sure that you're always working within your scope of practice. So Article 8, standards for nurse practitioners, does provide a provision that allows licensed nurse practitioners and certified nurse midwives to complete abortions by aspiration. So in order to do that, though, this rule, the Nurse Practice Act, this is not a rule, this is the law, says that one can do that, but you also have to go through an approved training course by the Board of Registered Nursing. And you must, this must of course be in your standardized protocol, and the standardized protocol must also include the extent of supervision that must be provided by a surgeon or a physician, and the surgeon and physician must have the relevant experience in order to delegate this act to you. The protocol must also contain procedures for transferring patients to the care of the physician or surgeon or a hospital, procedures for obtaining assistance and consultation from a physician and a surgeon, procedures for providing emergency care until physician assistance and consultation are available, and the method of periodic review of the provisions of the standardized procedures. It is considered unprofessional conduct for any nurse practitioner or midwife to perform an abortion by aspiration techniques without prior completion of training and validation of clinical competence. So just because this is added to your protocol does not mean that you're ready to do this. You have to go through the appropriate training and validate your clinical competence. So let's move into some additional other areas of California law that impact your scope of practice. And so the question would be, how does California Health and Safety Code regulate NP practice? And there are a number of ways that they do. And so we'll go through all these individual bullet points and talk briefly about the most important aspects of this. So let's look at our first case scenario. During your follow-up visit with a patient you have been seeing for a number of years, he tells you he was diagnosed with terminal cancer. He asks you to prescribe the death drug. Is this legal in California? So I know that the date is currently 2019, and we're in July of 2019 at the time I am recording this particular slide. And I know about a year ago that this law was repealed, but then the repeal has been put on hold. So please note that the things I'm about to say when it comes to this law in California may change before I have a chance to update the lecture. So at this point, at the time of the recording, it is legal in California. So Division 1, Administration of Public Health, Part 1.85, end of life Option Act. And so what this act says is that residents of California have the right to request an aid in dying drug if they meet the following conditions. They must be 18 years or older, must be a resident of California, the attending physician has diagnosed the individual with a terminal illness. So that is very key here in that the person cannot qualify under a terminal illness diagnosis that was made by a nurse practitioner. So you cannot make that diagnosis, which is why this is on your scope of practice, because you are not permitted to make that diagnosis when it comes to the End of Life Option Act. So you can make a diagnosis, but it cannot be used for the patient to request an aid in dying drug. The patient must voluntarily express the wish to receive a prescription for an aid in dying drug. The individual must document the request, and the person must have the physical and mental ability to self-administer the aid in dying drug. So a person who is seeking to receive a prescription for an aid in dying drug must submit 2 oral requests, a minimum of 15 days apart, and a written request to their attending physician. Again, notice this language says to the attending physician, so they cannot submit it to you, the nurse practitioner. So ultimately, the decision to do this is lies solely with a physician and not the nurse practitioner. The physician must receive all of the requests directly and not through their designee. So the patient actually has to physically give these requests to the physician. It can't be from the patient to the medical assistant to the doctor, or it can't be from the patient to the nurse practitioner to the doctor. It has to be directly. So if you get a request, you have to tell the patient that they need to give that request directly to the doctor and set them up for a visit with a physician. There is a specific form that the law requires the request to be put on. It has to be witnessed by 2 other adults who must attest to the following. The person must, they personally know the patient or have been provided proof of identity, the individual has voluntarily signed the form, and that they believe the person is of sound mind and not under duress, fraud, or undue influence. The individual is not a person for whom either the individual witness is not an individual that is the attending physician, the consulting physician, or a mental health specialist. And so they must meet all those 4 requirements. There are specific responsibilities of the attending physician that they must complete prior to prescribing the aid in dying drug. We'll not get into them because you can't, as a nurse practitioner, you can't do them. That's really the physician's privy. What you need to know is that if you are asked about this, you have to refer the patient on to the physician. If you're given a request, you can't accept it for the physician. So the other thing to know is that a consulting physician must be involved, and there are specific forms which are required to be completed. If you have additional information about this act, you can find it at the links below. How does the Paul Gann Blood Safety Act affect NP scope of practice in California? So this is Division 2 Licensing Provisions, Chapter 4.5, the Paul Gwynn Act in the Health and Safety Code. And this says something very interesting that kind of alerts me to kind of concerns me a bit. So anyway, I'll read this to you. Whenever there is a reasonable possibility as determined by a physician and surgeon or doctor or podiatric medicine that a blood transfusion may be necessary as a result of medical or surgical procedure, the physician, surgeon, or podiatrist, by means of a standardized written summary as most recently developed or revised by the State Department of Public Health pursuant to Subdivision E, shall inform directly or through a nurse practitioner, certified nurse midwife, or a physician assistant who is licensed in the state and authorized to order a blood transfusion, the patient of the positive and negative aspects of receiving autologous blood and directed and non-directed homologous blood from volunteers. For purposes of this section, the term autologous blood includes but is not limited to pre-donation, intraoperative, autologous transfusion, plasmapheresis, and hemodilution. So a couple of things kind of concern me or make me pay close attention to this act. And so what I believe this act is saying and is alluding to, well, it's not alluding to, it's pretty direct, is that if a blood transfusion is needed, informed consent must be done so that the nurse practitioner can do the informed consent and obtain the informed consent, but you must be authorized in your standardized procedure to do that and to order blood. So what concerns me about this is the first portion of the that is in red, and that is whenever there's a reasonable possibility as determined by a physician and surgeon or a podiatrist that blood transfusion may be necessary. That right there makes me believe that as a nurse practitioner in the state of California, you cannot make the determination that somebody needs blood. So later it says who is licensed in the state and authorized to order a blood transfusion. So the terminology is different there, and it makes you think, oh, well, you probably can order blood. However, the terminology used in the second reddened area is order blood. The terminology in the first is to make the determination that they need blood. And so that's two different things. So it really makes me wonder if a physician, surgeon, or podiatrist has to make the determination and then they tell you, okay, we'll go ahead and order it. So I, as of the recording of the screen, I emailed the California Board of Registered Nursing to ask them this question. I have yet to receive an answer from them. They did not have a straight out answer for me. So I don't know if I will ever receive an answer from them. But this language does concern me for how you practice in California. And so I want you to be very cautious about this. And my recommendation to you is to make sure that you can make the determination that blood is needed before you order it. So, and you have to do that by contacting the Board of Registered Nursing and getting a definitive answer. And if anybody out there that's listening to this gets a definitive answer from the board on this, then please let me know. So can a nurse practitioner pronounce death in California? So some of you may be out there saying, yeah, absolutely, or no, definitely, or no, you don't know. But so let's take a look at the California laws that help guide us on this. And so Chapter 3.7, Death, Article 2, titled Confirmation of Death of the Health and Safety Code, gives us a bit of an answer. And this code states that when a part of the donor is used for direct transplantation pursuant to uniform anatomical gift, and the death of the donor is determined by determining that the individual has suffered an irreversible cessation of all functions of the entire brain, including brainstem, there shall be an independent confirmation of death by another physician. Neither the physician making the determination of death nor the physician making the independent confirmation shall participate in the procedures for removing are transplanting a part. So what does this mean for your NP practice? I think this is really clear in one scenario. You cannot pronounce death on a potential organ donor, and two physicians have to confirm the death of an individual who is a organ donor. If you work in transplant and assist with organ procurement, you have to know that the confirmation of death must be done by two physicians. So then that leads me to the question, can you pronounce death on a person who is not an organ donor? So I cannot find a clear answer to this question in the California legislation. This Confirmation of Death Act only talks about organ donors. So if you say yes, you can, based on what you've seen by what other MPs do, I would say do not go by that. Many people do not know their own scope of practice or laws which impact it. Just because they are doing it doesn't mean they can legally do it. So you need to be cautious about that. And my recommendation to you is, because I do not have a clear a clear answer based off of California law that I can find, my recommendation to you is to default to not pronouncing death in a non-organ donor person or individual, and clarify again with the Board of Nursing if you can or cannot do it in a person who is not donating their organs. My general rule of thumb would be saying that if I can't do it in an organ donor, then I can't do it in a non-organ donor. So we had a similar situation in Texas with DNR, and so it was very clear on the outpatient basis in Texas that we could not we could not sign a DNR order that we call in Texas an out-of-state DNR order. And so, but what many people were doing was the law said that we couldn't sign this out-of-state DNR, out-of-hospital DNR order, and it's very clear about that. But it never addressed the in-hospital DNR orders, and so many people were writing DNR orders in the inpatient setting. Well, the law recently changed over a couple years ago that said that only physicians can write DNR orders in the inpatient settings. So I based on the original law saying that said before the inpatient law came into effect, I never wrote inpatient DNR orders because I knew the outpatient law was in effect and did not allow me as a nurse practitioner to sign an out-of-hospital DNR order. So my thought process all this time was, if I could not do it on an outpatient basis, then what makes me think I can do it on an inpatient basis? And so I have practiced like that for a number of years, and then all of a sudden, a few years ago, the law changed that said we can't even do it on an inpatient basis. So our board of nursing also had a position statement saying that we could not write it, and that was before the write DNR orders on the inpatient side, and that was before the law even changed. So I was always practicing safely. And so this law here in California reminds me of that same situation, and that is why I recommend to you to not pronounce death before you get it in writing from the Board of Registered Nursing that you can. How does Division 10 Uniform Controlled Substance Act Chapter 4 impact NP scope of practice in California? So this is another portion of the Health and Safety Code in California that tells you what you can and cannot do. And it has a number of things that it's required of you when prescribing or furnishing controlled substances. So this law specifically requires the prescriber to be licensed by their respective licensing board in order to prescribe controlled substances. It mandates that a controlled substance may only be prescribed for a legitimate medical purpose by a practitioner acting in the usual course of his or her professional practice. So you can't just go out and hand out prescriptions for scheduled medications to people who you're not seeing in your practice. One is not permitted to prescribe, administer, dispense, or furnish a controlled substance to or for any person or animal which is not under his or her treatment for pathology. May not issue a prescription which is false or fictitious. Prescriptions which do not meet the requirements of this law will not be filled by the pharmacist. So if you don't have the appropriate prescription and the items on the prescription, your prescription will not be filled. So considerations for prescribing controlled substance with an opioid to a minor. So this law has a section in here on how this changes when prescribing to a minor. And one must, this requires that you, if you're prescribing to the minor, must discuss the following with the patient or the guardian. And that is the risk of addiction and overdose, increased risk of addiction to an opioid, for an individual suffering from both mental and substance abuse disorders, the danger of taking an opioid with a benzodiazepine, alcohol, or other CNS depressant. This does not apply in the following situations: if the treatment of a minor is associated with emergency services and care, if the treatment of a minor is associated with or incident to an emergency situation, and 3, if in the judgment of the prescriber, fulfilling the above requirements would be detrimental to the minor's health or safety or violate their legal rights to confidentiality. So, if you are one, if you're an MP who has the scope to prescribe to minors and you're going to prescribe a controlled substances, you have to be aware of this law and this requirement in the Controlled Substance Act in California. You must follow these things and then you must document it. If you believe there is an exemption, that your situation falls into an exemption, you need to document the situation and document that you fall into an exemption. If you don't fall into exemption, you need to document that you've discussed the risk of addiction, that you have discussed the risk of addiction to an individual suffering from both mental and substance disorders, if that applies, and the danger. You have to document that you've talked to them about the danger of taking an opioid with these other medications as well. That is part of your professional obligation to follow this law and make sure that you document correctly. So we're still answering the question, how does the Controlled Substance Act impact your scope of practice? This act also says that orders written for controlled substances on patients in a county or licensed hospital are exempt from the regulations written in this law. However, the order must be in writing in the patient's record, signed by the prescriber, dated, and must state the name and quantity of the controlled substance ordered and the quantity actually administered. These orders must be maintained for 7 years. So this law also says that prescriptions for controlled substances for persons with terminal illness do not have to be on the required prescription form, but must contain all the required information and write 11159.2 exemption on the prescription. So, this act says that you have to have the required prescription form from a certain print shop. And so what this is saying here, this last bullet point, is that in the incidence that this is a terminal illness, that you can write on the prescription, and you don't have to use the required prescription, but you can write on the prescription this exemption, and you have to use what is in quotes here on the screen. So as I was saying, your prescription forms must be obtained from an approved printer. Prescriptions must be tamper resistant, and a new law that went into effect in March, a new state law that went into effect in March 2019, requires the prescriptions to have been printed with a serial number and a barcode. The process one has to follow, and the forms can be found on the following website, because you have to order them, and so you have to register with at this website in order to be able to order the prescription. The process will require you to submit your fingerprints and a number of other things. It is important that you follow the process completely and exactly so that you can obtain your prescription forms. You must have prescribing privileges before obtaining prescription forms. This will be verified before the forms are printed, and you must have a DEA before you get these forms as well. The forms are provided directly to the prescriber in person or by certified mail. Section 1116.62.1 describes the many items which must be printed on the prescription forms. We will not go through them all, but you are responsible for reading this information and understanding it. The prescription form must have the pre-printed name, category of license, license number, DEA number, and address of the prescribing practitioner. Section 11164 describes what is required on the prescription. You're required to comply with this law, otherwise you cannot prescribe scheduled medications. The prescription must be written using the appropriate prescription form. The prescription must be signed and dated by the prescriber, have the prescriber's address and phone number on it. Refill information, the name, quantity, strength, and directions for use. The prescription must have the patient's name on it and their address. Prescriptions for Schedule 3, 4, and 5 medications may be given orally or electronically submitted. The information contained on the prescription must be in the patient's written record. So you have to keep that in the record as well. So writing the prescription alone is not enough. So they're tying you into appropriate documentation. So California has a prescription monitoring program, which they title Cures. And this was mandated in the Controlled Substance Act that we are discussing. And CURES stands for Controlled Substance Utilization Review and Evaluation System. This is an electronic system which tracks patient scheduled medications and prescribers' patterns. It contains patient information such as their name, their date of birth, their address, the prescriber's name, the DEA, pharmacy name, pharmacy license number, date prescription was dispensed, the prescription number, the drug name, quantity, strength, and number of refills remaining. So when do you have to consult Cures? So you would need to consult Cures the first time a patient is prescribed, ordered, administered, or furnished a controlled substance unless an exemption is present within the 24-hour period or the previous business day before prescribing, ordering, administering, or furnishing a controlled substance unless the exemption is present, before subsequently prescribing a controlled substance if previously exempt, at least once every 4 months if the controlled substance remains part of the treatment plan. The information contained in Cures is considered private information and it is your responsibility to protect it like you would any other HIPAA information. So providers are exempt from checking Cures in the following scenarios. 1, while the patient is admitted to or during an emergency transfer between a licensed clinic or outpatient setting or healthcare facility or county medical facility. Number 2, in the emergency department of a general acute care hospital and the controlled substance does not exceed a non-refillable 7-day supply. 3, a part of a patient's treatment plan for surgical procedure and the controlled substance does not exceed a non-refillable 5-day supply when a surgical procedure is performed at a licensed clinic, outpatient setting, healthcare facility, county medical facility, or place of practice, or the patient is receiving hospice care. So those are the exemptions. So there may be times where you are not able to access Cures in a timely manner. So if this happens, and if another individual with access is not reasonably available, and there, as far as I know, there's not a definition for what's reasonably available, a 5-day supply of the controlled substance can be prescribed, ordered, or administered, or furnished as long as there's no refill allowed. The provider must document in the patient's medical record the reason for not consulting Cures. And I would specifically say it was not, if there was a technical difficulty with the website, I would specifically put that. Whatever the reason was, I would be very detailed in that in your documentation. There are exemptions for technical difficulties. If you experience technical difficulties, you are to contact Cures and notify them fairly immediately. The provider must promptly work to resolve the technical issue. Once you are licensed and you have a furnishing number and a DEA number, you can apply for access to Cures. Your access to Cures can be revoked for unprofessional conduct. This is a privilege, not a right. This is a requirement too. If you lose access to Cures, you will need to notify your employer. This will have a tremendous impact on your job. Additional information about Cures can be found at this link, and you can register for Cures when you have your furnishing number and your DEA and you're fully licensed at that link below. Other provisions that are mandated in the Controlled Substance Act that you should be aware of. 1, you cannot prescribe a controlled substance for yourself. You cannot antedate or post-date a prescription, so it has to be the correct date. Persons are prohibited from attempting to get a prescription for a controlled substance using deceit, fraud, misrepresentation, subterfuge, or by concealing a material fact, and persons may not give a false name or address to obtain a prescription for a controlled substance. So if you suspect that a person is doing number 3 or 4, then you need to probably report them. So here's the last few things that you need to know about the Controlled Substance Act in California. You cannot prescribe a controlled substance for yourself. It is illegal. You cannot antedate or post-date a prescription, so it must be the day that you're filling it out. It must be dated on that day. Persons are prohibited from attempting to get a prescription for a controlled substance using deceit, fraud, misrepresentation, subterfuge, or by concealing a material fact. Persons may not give a false name or address to obtain a prescription for a controlled substance. If you suspect that somebody is doing that bullet point 3 or 4, then you are obligated to report them to the authorities. So you have been thinking lately about how busy you are after graduation and how much you miss school. You realize that you need some help and wish someone could clone you. So this is just a little bit of tidbit of information. I hope that you're never in a situation where you have to quote this law. Um, but California Health and Safety Code does prohibit human cloning, so that is something that is not permitted in California, and I believe that that is illegal across the states. I think there's a federal statute about that as well. So anyway, you should just know that it's not legal um, to do that. So and this is the law and the link to the law. So you are working as senior patients in clinic today, and the office manager comes to you and asks you to complete and sign the death certificate for a patient who died 2 days ago. Can you do this? So Division 102 Vital Records and Health Statistics, specifically Chapter 6 and Chapter 6, Article 2, and Article 4 address this. So Chapter 6, Death Registration, Article 2, responsibility of the attending physician specifically states that it is the attending physician's responsibility to mark on the death certificate the cause of death, and any significant issues that contribute to the death. It also says that a physician can designate to another physician to complete this task. So you cannot add the diagnosis or the cause of death or anything to the death certificate. So if you're ever in a situation where you're asked to do that by the physician, you should promptly tell them that it's against the law and you're not permitted to do that. So Chapter 6, Death Registration, Article 4, Content of Death Certificate, specifically says that it must be signed by a physician. So again, if you are asked to sign the death certificate by someone in your practice or by the physician, you have to say that you have to politely decline and say that you're not permitted by law to sign the death certificate. So the Health and Safety Code in California has an interesting code, and under its Division 104 Environmental Health, Chapter 4 Treatment of Cancer and Other Serious Diseases. The purpose of this law is to ensure that the public receives full and accurate knowledge as to the facilities and methods for the diagnosis, treatment, and cure of cancer available in California. Upon a diagnosis of breast cancer, the physician and surgeon, note that this says the physician and surgeon, this means that you are not permitted to do this. So upon the diagnosis of breast cancer, the physician and surgeon, meaning the primary provider who initially referred the patient for the screening or biopsy, if different, the provider who has made the diagnosis of breast cancer and initially consulted with the patient about the treatment shall give the patient the written summary in layperson's terms of alternate efficacious methods of treatment that may be medically viable, including surgical, radiological, and chemotherapeutic treatments, or a combination thereof. This must be documented in the patient's chart. The failure to do this is considered unprofessional conduct. There are written summaries that are available on the California Board of Medicine's website, and clinic owners are required to have a notice posted for patients to read that the physician and surgeon is required to provide this information about breast cancer. This law also addresses gynecological care as well, and it says that the medical care provider, primarily responsible for providing to a patient an annual gynecological examination, shall provide the patient during the evaluation, the examination, a standardized summary in layperson's language, a description of the symptoms and appropriate methods of the diagnosis for gynecological cancers. Medical care means a healthcare professional licensed pursuant to Division 2 of the Business and Professional Code. Physicians and surgeons are urged to provide a written summary to those patients who have prostate cancer as well. And clinic owners are required to have a notice posted for patients that say physicians and surgeons are urged to provide a summary of alternative efficacious method of treatment for prostate cancer. How does Chapter 6, Drugs and Devices, Article 4.5, the Right to Try Act, affect NP scope of practice? This law allows that a manufacturer of an investigational drug, biological product, or device may make an investigational drug, biologic product, or device available to an eligible patient. The law also states that a licensing board cannot revoke, fail to renew, or take any other disciplinary action against a physician's license based on their recommendation to an eligible patient if the recommendation is consistent with the protocol. So what concerns me about this law is the red verbiage. Because of this wording, I do not believe you as an NP can make a recommendation for an investigational treatment. I recommend that you do not do this, and if you find yourself in the need to do that, contact the Board of Registered Nursing to clarify if making this recommendation is within your scope. Refer the patient to a physician to make this determination until you know if you can or cannot make this decision. So let's look again back at the California Business and Professions Code. And so this is different information that is not specifically in the Nurse Practice Act. So Division 2, Healing Arts, Chapter 1, General Provisions, Article 7.5, Healthcare Practitioners. This is the law that requires that you display your name and your state-granted practitioner licensure type while you're working. This law goes on to further say that physicians must display their highest level of academic degree, but that is not a requirement of nurses. So Division 2, Healing Arts, Article 15, Sexual Orientation Change Efforts. This is another portion of this Business and Professions Code, and this law prohibits a provider, specifically a mental health provider, from engaging in sexual orientation change efforts with a patient under 18 years of age. Doing so is considered unprofessional conduct and will be subject to disciplinary action. This law applies to any person designated as a mental health professional under California law or regulation. So the California probate law. And so you may be thinking, wait, are you serious? The probate code regulates our scope of practice. Well, as a matter of fact, as it does. So, and that's what we're going to explore. So Division 4, Healthcare Decisions, Part 4, Request regarding resuscitative measures. So the probate code in California is what contains the advanced directive laws. So Section 4652 of this law prohibits the person who is responsible for making healthcare decisions for a patient for the following reasons. So their surrogate cannot make decisions when it comes to commitment or placing that individual into a healthcare facility, cannot make a decision regarding convulsive treatment, psychosurgery, sterilization, or abortion. So you have to know that, because if you want to get a surrogate to ask for permission for one of these things, you can't ask them to do that because they can't make that decision. Section 4654. This law does not authorize or require a healthcare provider or healthcare institution to provide healthcare contrary to generally accepted healthcare standards. So you are not obligated under this law to provide care to an individual that is outside the scope of standards. Our generally accepted scope of standards or standards of care. So Section 4658, unless otherwise specified in a written advanced health care directive, for the purposes of this division, a determination that a patient lacks or has recovered capacity, or that another condition exists that affects an individual's health care instruction or the authority of an agent or surrogate, shall be made by the primary physician. So what this is telling you is that an individual, basically an individual who has a power of attorney or advance directive and has appointed somebody to make decisions for them, has to lack capacity. The the um, the decision as to whether someone lacks capacity or not is to only be made by the physician. You as the nurse practitioner cannot say they do not have capacity. That is a physician only thing in the state of California. Section 4675, if an individual is a patient in a skilled nursing facility when a written advanced healthcare directive is executed, the advance directive is not effective unless a patient advocate or ombudsman, as may be designated by the Department of Aging, signs the advance directive as a witness. So be aware of that. A healthcare provider may not require or prohibit the execution or revocation of advance directive as a condition providing healthcare admission to a facility or furnishing insurance. Section 4695 states that a person with capacity may revoke the designation of an agent by a signed writing or by personally informing the supervising healthcare provider. A person with capacity may revoke all or part of an advance directive other than the designation of an agent at any time and in any manner that communicates an intent to revoke. Section 469, a healthcare provider who is informed of a revocation of an advance directive shall promptly communicate the fact of the revocation to the supervising healthcare provider and to any healthcare institution where the patient is receiving care. So section 4730 through 4736 is a summary of healthcare provider responsibilities. And it says the supervising healthcare provider must inform the patient of a healthcare decision that was made for them, of the decision, and the person who made the decision. If you know of the existence of an advance directive, you must request a copy of it and put it in the record. If you know about the revocation of a power of attorney for healthcare or a disqualification of a surrogate, you must make a reasonable effort to notify the agent or surrogate. The primary physician who makes the determination that the patient lacks capacity or has recovered capacity must document this promptly in the medical record. Again, a physician only may document the lack of capacity or the recovery of capacity. And so that means they are the only ones that can make those determinations. One must follow the decisions made by the agent or surrogate, except when this is contrary to generally accepted healthcare standards or it is against a policy of the institution and the policy was timely communicated to the patient or person authorized to make the decision. One who declines to comply with the decisions made must inform the patient or the decision maker, provide continuing care until a transfer of facilities or providers can be accomplished, and in all cases continue palliative care and pain relief. So let's look at the California Vehicle Code. A patient asks you to sign an application to obtain a handicap placard. Can you do this? Yes, you can absolutely do this. This is allowed for in the vehicle code, and you can see that in this third bullet point on the screen that it does allow a nurse practitioner to sign for a placard. Nursing home law and NP practice. So the Board of Registered Nurses requires that you follow federal law when it comes to seeing patients in long-term care facilities who receive reimbursement by Medicare. You must the generalities of this law say that you must be working under the supervision of a physician. The physician must admit the patient and approve in writing the admission, do the initial visit, and must do all required visits. So you have to alternate visits with the physician, and because they have to be involved, and you cannot do the H&P and you cannot write the admission order. This all comes from Medicare requirements, and that's the federal law that the Board of Nursing is requiring. So this is pretty consistent from state to state to state because this is federal law and not state law. And so you can find more information from the Board of Nursing at that link below. Restraints and seclusion and NP practice. In California, NPs may order restraints. This must be an approved activity in your standardized procedure. You must do so in accordance with the facility policies and must be familiar with the hospital conditions of participation for patients' rights. You can find additional information in the link from the Board of Nursing on this. And so state laws as it goes to restraints and seclusion, this come from federal laws, the federal code, which is specific to Medicare again. So additional things to ask your Board of Registered Nursing. Can you make a decision to withdraw care? I do not see anything in the legislature which addresses this, but I do believe that it is likely you cannot do this in California. If you cannot, this will certainly have an impact for those nurse practitioners who work and are trained in acute care. So your adult geri, your PD, and your neonatal. If you're running a code and you're at a point that it needs to be called because you're not going to get your patient back, if you cannot make the decision to withdraw care, you cannot make the decision to stop the code. You will have to get the physician on the phone at a minimum to make that determination. It is best to find out from your Board of Registered Nursing before you're in this situation if you can make the decision to withdraw care. So the other thing to certainly ask is, can you write a DNR order? You can sign a PULSE, which has a DNR order on it, but I'm not certain you can write a DNR order in California. There is a DNR form in California that one can use instead of a PULSE, and this can only be signed by a physician. This would suggest that you cannot write a DNR order inpatient or outpatient. I have not seen any legislation in California which addresses this, so it is best to contact your Board of Registered Nursing to find out before you do this. And it's always safest to default to not doing it since the law is not clear. California is very much like Texas in that it has very restrictive practices. So in Texas, we can't do either one of these things. But there is specific verbiage in some of the laws that tell us that we can't do this. So my final words: between a rock and a hard place. First, do not assume that you can do something just because somebody else is doing it. That will get you in trouble. That just because they are doing it does not necessarily mean that it's legal or it's okay. So this is about the third time I've said this throughout this lecture. So by now you should know that just because they're doing it, it doesn't mean that it's okay. It may mean that they just don't know they can't do it. So I want to tell you a bit of a story about a patient. This was not my patient. One of my colleagues told me this story. She is an intensivist and works night shift at a large institution. She was about to get off of her shift in the morning around 8 a.m. when she received a call from the emergency room. The emergency room called her and told her they had a female patient in their 30s that came in. She was hypoxic. When she came in and was diagnosed with a PE. They had to intubate her. She's on 100% FiO2 with SAT still, with oxygen levels still at 85%, even on intubation and 100% FiO2. And they asked her, the ED physician asked the nurse practitioner on call for the intensivist service if they would recommend giving her TPA. So the problem, the treatment in this instance, this is an unstable PE, and the treatment is appropriately given, it is appropriate to give TPA. So the nurse practitioner, knowing this, said, "Oh, well, typically we would, but why are you asking me this question?" And so then the ED physician says, "Well, she just had surgery, abdominal surgery a week ago." So recent surgery is a contraindication to TPA. So this is an example of when one is between a rock and a hard place. In this patient, should she be given TPA with this significant contraindication, she is likely to bleed out and die. If she doesn't get the TPA, she is likely to die from the PE because she's obviously not responding to oxygen therapy, and this must be a pretty significant PE. So that's what I mean by a rock in a hard place. If the standard treatment would harm the patient, and not giving the standard treatment would harm the patient. This is never a decision that a nurse practitioner should make. I don't care if you are in an independent practice state, or a collaborative state, or a supervisory state. One should never make that decision. This is a physician only decision regardless of where you're practicing. Um, and so ultimately, what happened in this scenario is that they gave the physician, the intensivist decided to, the nurse practitioner did not make this decision. She called the physician. The physician went to go see the patient, made the call to give her the TPA, and unfortunately, the patient did die secondary to hemorrhage from the TPA. So, that is that's a rock in a hard place. Those, again, I can't impress this enough on you. Those type of decisions and scenarios are not ever within our scope of practice as nurse practitioners. So this is my last slide. These are all the links to various laws that I have found in California. Use this in references as you need that. All right, thank you. That's the end of this lecture.